Welcome back, everyone. We're now going to move on to the second technical session for the day. Where we'll talk a little bit about the methods to study health effects of air pollution. We have two very good talks from experts in exposure assessment and epidemiology, and we will try to have a short Q&A session following the two talks. I would like to welcome the chair for this session, Dr. Tamara Schikowski, who is an environmental epidemiologist. She's a co-chair of ISEE Europe and also leads the group on environmental epidemiology of lung, brain, and skin aging at the IUF-Leibniz Research Institute of Environmental Medicine in Duesseldorf. Dr. Tamara has longstanding experience in conducting environmental epidemiology studies and has led work both in Europe and also across the world. Welcome, Tamara, over to you.
Thank you, Pallavi, and welcome everyone. I'm very happy and excited to share this session. This is the last session for our day. The session will be on progress in methods to study health effects on air pollution. We have two very exciting speakers, and first speakers will be Dr. Kees de Hoogh. He's an environmental exposure scientist at the Swiss Tropical and Public Health Institute in Basel, Switzerland. And he's a visiting scientist at the Institute of Risk Assessment Science in Utrecht University and the TNO Environmental Modeling, Sensing and Analysis Institute, also in Utrecht. Kees has been part of a lot of European studies, large European studies, and we work together in Switzerland as well. And he's specialized in spatial modeling and exposure assessment for studies on environment and health. His recent focus involves cutting-edge fine-resolution spatial temporal modeling to derive refined exposure using satellite and accelerate data. Kees will talk about how to measure air pollution and air quality. And Kees, the floor is yours now. I think you have to unmute yourself. I think
there, I just had to find the unmute button. Thank you very much. Thank you very much, Tamara, for the introduction, and thank you, the organizers, for inviting me to this very nice workshop. I'm honored to be a speaker on this. And my talk is all about how we measure air quality and how do we assess exposure to air pollution. Let me just get to the next slide. So what I want to talk about this afternoon is just a brief introduction to what is environmental exposure assessment, then go straight into air pollution exposure assessment and try to answer some of the following questions. Why do we need it? How can we conduct exposure assessment? What tools, equipment, and data are required for this? And what are some of the challenges in measuring and estimating air pollution exposures? So first, a brief introduction to environmental exposure assessment, but it all has to do with the environment health chain. We have a, oops, I went too quick. We have a stressor and a receptor here on the left. And if I use my mouse, a stressor and a receptor. And of course, where this stressor and receptor come into contact with each other, there a exposure occurs. So we have a source, it emits environmental concentrations, emissions, and it leads to environmental concentrations. It comes into contact with a receptor, which leads to an exposure. The exposure then leads to a dose, which potentially then leads to a health outcome or a disease. So this is, for example, an image from the Environmental Protection Agency in the US, which shows a drum, a set of drums with chemical stuff in it, and it's corroding, and it's emitting all sorts of pollutants. Some of it leaks into the soil, some of it's released into the air. And you can see there are different exposure routes whereby this comes into contact with the population. And we have three specific exposure routes: inhalation, ingestion, and dermal contacts. So those are sort of the ideas of exposure assessment. And of course, with air pollution, we mainly look at the inhalation, but also at dermal contact, because we also have atmospheric deposition. So there are different methods to assess exposure, and we can sort of divide those into direct and indirect methods. We see here a range of methods, and they are sorted from top to bottom into metrics position. So the top ones are very high in precision and the bottom ones are lower. And you see on the top, we have measurements at the individual level. So we have things like biomonitoring or personal monitoring. And hereby we basically measure the contaminant in case of biomonitoring, for instance, in the urine or blood or in hair. And we get a very accurate idea of how much that individual is exposed. The problem with these direct methods is that they're very expensive. We can only apply that to not many people because of the costs involved and the time involved. So what we normally do in epidemiological research, we have to go to indirect assessment because we can then apply that to a larger population, for example, cohort populations. And you see a whole range of methods here on the bottom in the indirect box, which do that and apply that to large populations. And they also sorted in higher to lower precision. And I will pick out a few of these in my air pollution exposure assessment examples. So let's go straight into that. And the first question really is, why do we need it? Well, we need this, and of course, this has already been shown in the previous talks. We need this data to feed into epidemiological research. And for that, we need high resolution temporal and spatial air pollution exposure data. And this depends really on which research question we ask. And we can divide into chronic and acute health effect. So for the chronic health effects, we need long-term exposures, ideally going back in time. So we need annual mean, and these we are then linked to chronic health effects like lung cancer or cardiovascular diseases. Now the other bit we need are acute health effects research. So for example, research to lung function, decrease in lung function, for example, and we need short-term exposure to that. So there we actually need a time series of daily means, which are around the time we do the lung function test. So these are two different types of exposure data. And of course, we already looked at this. We have a number of sources where pollution comes from. So I won't go into this, I'll skip this. But how can we measure air pollution? And again, we've already seen examples of routine monitoring data at the presentation, for example, from Alberto. And these, here on the bottom right is a typical routine air pollution monitoring station, and it's there for a long time. It measures continuously a number of air pollutants at a very fine temporal resolution. So it's every second, every minute you have this concentration. But of course, it's it's static. It's somewhere, it doesn't move. So we only have it at that particular location. We also have mobile air pollution monitoring. And for instance, here you see a picture of a Google Street View car in the middle. Apart from some of these cars were also kitted out with air pollution monitoring equipment. So not only the camera here on top, but also an inlet here at the top of the window. And that's where air pollution got measured whilst these cars were driving around these cities. So that's a mobile method. We also have passive measuring methods. So for example, here on the left, you see PALMS tubes, which measure air pollution by diffusion. It's a very low cost way of measuring air pollution. The only disadvantage is there that you have it for a longer time period. So you only get a week or 2 week average air pollution concentration with that. But the advantage is you can almost hang it everywhere. And then last, we have sensors, and so here on the right, top right, you see a example of a sensor like this, and this is one which is used on a bicycle, and I'll show you an example in a minute how that was used. We've seen this slide before again, also from Alberto. I had the same idea. I was looking at air pollution data across Europe, actually from last month, one particular day, and also noted sort of a slight lack of air pollution data coming from Southeast Europe. But this, of course, is, as Alberto said, a really good source of air pollution data, especially if you look across the whole of Europe. So we do monitor it. And this is this example of a sensor. So here on the right, we see the same sort of sensor as we saw earlier on the previous slides, just an older version. And this was used on 500 bicycles in the Netherlands. And you can see here how these bicycles, how these people were cycling across Utrecht in this case. So you can see the cycling routes, but you also see the high versus low exposure routes. And this is a very nice example of how you can use that data and visualize it, and it becomes straight away informative for the public. And come to the next question we want to answer is, how do we then model air pollution? Well, generally speaking, we have two different methods to do that. One is an interpolation method, and one is a source receptor modeling method. The interpolation one uses monitored, for instance, these airbase or routine monitoring sites. And what it does, it's trying to fit a model through those sites using basically with or without covariance. And for instance, methods doing that are, for example, kriging or land use regression modeling. And I'll give you an example of land use regression modeling in a minute. The other method is source receptor modeling. And these models try to simulate relationship between the source and the receptor. And an example of that is dispersion modeling. So what does that look like when you apply these approaches? Well, this is a map of some monitoring sites across London, NO2 monitoring sites. And basically using these sites, we can come up with 4 different methods. The bottom 3 actually uses those sites to come up with these maps. So the nearest monitoring, inverse distance weighting, and LUR use the information measured at those locations to come up with these maps. And you can see straight away the increase of accuracy from the bottom to the top. And then dispersion modeling is a completely different method, which doesn't actually use these sites, but you can of course use the sites to validate that. One of the data, well, recently, I say for the last 10, 20 years, we're starting to use more and more in air pollution modeling is Earth observation data. And the type of data we use are satellite-derived air pollution, land use data, the Korean data set, it's all remote sensing data, green space data, and light by night. And all these different types of data go into some of our models. And just to explain one of those ones, it's the aerosol optical depth data. Basically, this is an instrument in a satellite. So you have a satellite which goes around the Earth and comes over Europe at about 10 o'clock in the morning, for example. And it measures 2 sunbeams, one direct sunbeam from the sun and one sunbeam reflecting off the surface of the Earth. And of course, this sunbeam reflecting from the surface of the Earth is intervened by the column of aerosols. So if there's a lot of aerosols in the column, then there is a lot of scattering and not much of that sunbeam comes back to the satellite. So if you then look at the difference of these 2 beams, there will be a large difference. So then what it measures is a large AOD, which gives you basically a large pollution estimate. Now, the downside of this measurement is that it doesn't really work when there are clouds. So if it's a cloudy day, this is a very non-cloudy day, so you have a perfect AOD measurement. But if it's cloudy, then this method will not work. But in our modeling approaches, we deal with these issues. So what can we do with all that data? So we can build spatial air pollution models. And this is an effort we've done actually as part of an HCI project, the ELAPS project, where we looked at health effects due to low-level air pollution levels. And in these models, we incorporated the satellite observation data, but also other data like dispersion model estimates and land use and road data. And we linked this to the monitoring data I was showing earlier on the slides and Alberto was showing, and then developed regression models on top of that. And that way we were able to develop robust continental-wide air pollution models. And the scale of this is about 100 meters. So if you zoom in, you get a 100-meter pixel with an air pollution estimate. Now you can see we are missing here large parts of Southeast Europe in this model, but we are trying to improve this now in a new project called Expanse, where we are now trying to come up with models for the whole of Europe. So filling in the gaps here, similar models, but then also for all years going back to the early 2000s. So this is work in progress. Now, land use regression modeling, just very briefly to explain what it actually is. So what it does, is we have measurements at measurement locations, but also at those locations we have information of predictor variables, and those predictor variables are indicators of emission activity. So we can then create a regression model as with NO2 measured as the dependent variable, and have other predictor variables which could explain that variation as in a regression model. So what we come up with is a simple regression model where we say, okay, our predicted NO2 is a constant plus, in this case, just 3 different predictor variables. And the beauty of that is then you can apply that model to the whole area. So you can apply it to locations you did not measure before. So that could be, for example, cohort address locations. And then you basically can link estimated NO2 concentrations, in this case, to a address, and so inform a health study with air pollution exposures. Now you can make that more complicated. I won't go into this graph, but what we can do then is come up with daily estimates of air pollution exposure. So in this case, we did a study where we, for 13 years, provided daily concentrations of NO2. And here I just show you 7 consecutive days of NO2 concentrations across Switzerland, again at a very fine spatial resolution of 100 meters. But we have this now daily for a 13-year period, and that will also then go into health studies. Now, the other way to model air pollution was using dispersion modeling. So this is a completely different way of doing it. It's actually start with the source of the data, and from this source you can see the emissions from a stack, for example, is being affected by all sorts of factors, meteorological factors mainly, but also the stack height, for example, and the emission rate, etc. The terrain it flows over. This was computed into or set into a Gaussian plume model in this case, so it becomes a mathematical model. And with that model, you can then also develop and predict air pollution concentrations as a result of emissions from, in this case, just a single point source. So these are useful models, for example, if you look at specific point sources or So challenges in air pollution exposure assessment. Well, the historical exposure estimation, that's one we are still dealing with, because going back in time becomes more and more difficult to assign accurate exposure estimates, but we need it because lots of our cohort studies, and this is what Evie will show later, we have a historical health data we like to assign. So this is something we are looking into. Of course, a lot of the studies use residence-based exposure estimation, ignoring personal activity patterns. So this has to be addressed. And for example, vertical gradients are not really addressed in exposure, air pollution exposure assessment that well. This has implications, for example, for studies in cities with a lot of high-rise buildings. But we are making developments. So hybrid models, as I said, we're combining lots of different data sources to come up with more improved models. And also new technology will help us addressing some of these issues about time activity patterns. So GPS, smartphones, and local sensors. And the last slide really is about how we then can assess air pollution exposure at a small area scale. So there are different approaches, of course. One of them is just use monitoring data to look at trends, either existing or new monitoring data you do yourself. This can then be combined with geostatistical or land use regression models to come up with maps of the area. Another way of doing it is, of course, using dispersion modeling. And the last one is combining all this in so-called hybrid models. But it also depends on the question you want to answer. Do you want to look at specific sources? What is the resolution of your health data? And for what time period? And this is probably something Effie will address after this. And with that, I want to close my talk, and thank you very much.
Thank you, Kees, for a very nice and informative presentation. I think we have to consider the time, so we move on straight away to Effie. Effie Samoli. She's an assistant professor of epidemiology and medical statistics at the School of Medicine, National and Kapodistrian University in Athens. Her research interests focus on health effects of air pollution and the related statistical methods. She has been part in many funded collaboration projects across Europe and is has been co-investigator of large European projects. She has been part of WHO and HEI reviews committees for air pollution and on health effects. And Effie will be talking on epidemiological design to study the effects of short and long-term exposure to air pollution. So Effie, the floor is yours.
Thank you, Tamara, for the introduction, and thank the organizers for this very useful webinar in our part of the world. I will briefly present the epidemiological designs to be used depending on the research hypothesis we want to investigate, and also the availability of data. Now, one major classification in the epidemiological designs used in air pollution epidemiology is based on what kind of effects we are trying to estimate. If we are trying to estimate effects following a short-term exposure that will associate changes in a health outcome according to changes in exposure a few days or up to a few weeks prior, or we're interested in investigating long-term health effects of long-term exposure. And we define here long-term exposure as at least an annual exposure period. Probably there is a continuum between short-term and long-term effects, long-term exposure effects, and the particular lags, the delay between exposure and health effects varies depending on the outcome assessed, and it's always under investigation. So as previous speakers have mentioned, Air pollution epidemiology has several specific aspects that are not met in other fields of epidemiology. And one major difficulty is the exposure assessment, because exposure to air pollution is population-wide. We are not exposed to single pollutants, but we are exposed to pollutant mixtures. Usually these mixtures may be in differential levels depending on the part of the country. As Kees previously presented, there are different kinds of error associated with the kind of exposure metric we are intending to use. And as previously said, also the exposure period that is of most health relevance, it's not always clear. Regarding the outcome definition, a particular difficulty in air pollution epidemiology is that we are trying to assess very small risks, but these small risks are hard to assess properly through biostatistical methods because they're so small in the presence usually of higher confounding, but they're very important considering public health, exactly because everybody is exposed to air pollution. Now, because intervention studies such as randomized clinical trials are not ethical to be performed under air pollution epidemiology, and we are mostly using observational studies to assess related health effects, the issue of causality has been raised through the related research. Depending on these issues, I would like to stress how important it is that we have the collaboration between all the different scientists involved in air pollution epidemiology, ranging from exposure experts to biostatisticians, epidemiologists, and policy relevant officers. As presented earlier by Dr. Anderson, there have been a lot of health effects associated with air pollution. The vast majority of the population is expected to have minor changes in mild symptoms, such as lung function decrements. But as we go up to the severity of the symptoms, air pollution is associated with hospital admissions and premature mortality. Considering health impact assessment and cost-benefit analysis, as already presented in various talks, most of these assessments are based on mortality outcomes, mainly due because of the validity and the availability of such data. So to present briefly, I will divide air pollution designs, the epidemiological designs to study air pollution health effects according to the exposure. So we research short-term exposure health effects using either time series studies, case crossover designs, or panel studies, while we study long-term exposure using ecological geographical studies, cross-sectional studies, cohort studies, and case control studies. And I'll just go briefly to present main characteristics of each design and some paper illustrating the application of these designs. So to begin with, how do we study health effects of short-term exposure? The easiest way, due largely to the availability of data, is the time series design. You can see here in the slide, the day of observation is the unit of observation, and we follow up the changes in daily air pollution. You see here the change in black smoke in Athens during the 90s. And we are trying to associate changes in air pollution measurements, usually from fixed sites, monitors, to changes in statistically routinely collected data, such as number of daily deaths, according to some cause-specific mortality outcome, or to all-cause mortality, or to hospital admissions. So we are trying to assess the association between changes in daily air pollution with changes in the time series of the related health outcome. Now, exactly because this kind of data are available, we have daily monitoring data on air pollution, and we have a statistical routine time series collected at least on mortality outcomes, even in areas where other systems of data collection are not so widespread. This is the most easy way to start and investigate the health effects of air pollution. Under this concept, the only other factors that may confound the association between our exposure and the health outcome are other time-varying confounders, such as seasonality, temperature, long-term trends in air pollution concentration, or changes in lifestyle patterns. And these are also data that are routinely collected and easy to address. Further, time series studies, because they are available for a large period of time. I mean, in Greece, I know that we are measuring PM2.5, for example, since 2012, I guess. We have a large data set to work with, which provides us with the appropriate statistical power exactly to detect small risks in the presence of strong confounding. And a disadvantage from time series studies is that there are data on more sensitive health outcomes is not available. The most usual application of time series data is to collect time series related data from multiple cities covering a country or several countries, and then perform the analysis for each city separately, and then combine city specific effects using meta-analytic approaches to reach a pooled risk estimate. Here you see a rather recent publication that was mainly in the south of Europe. There were Italian, Greek, Spanish, and one French area that was included to study the associations between particle metrics and mortality. And you can see, of course, that the lag between PM2.5, for example, that all-cause mortality was different. We found stronger effects considering 2 days exposure, while we find stronger effects for cardiovascular mortality or respiratory mortality considering 6 days exposure. And of course, as everybody has mentioned before, PM2.5 was significantly associated with increases in all-cause and cause-specific mortality. Time series studies results have been used to support air quality guidelines when addressing short-term exposures, and they have also been used for health impact assessment, considering the change in the daily levels of pollutants and how these may affect mortality outcomes. On the left graph, you may see the results from the Athens project that estimated the number of preventable deaths per 100,000 residents if the daily PM10 levels in the 19 cities included in the study were decreased by 5 micrograms per cubic meter. So you can see, for example, that for Ljubljana, about 3 to 4 deaths will be avoided annually. These results, of course, fit into annual analysis on health impact assessment, and related changes in the Athens project estimated, for example, that if annual level for PM2.5 were able to conform with WHO guideline of 10 micrograms per cubic meter annually, this will include, for example, in Ljubljana, a life expectancy gain of about 14 months. So these kinds of results fit into health impact analysis. Time series studies have been further used to address other issues, such as the shape of the exposure response association, the concentration health outcome association, and if this is linear, meaning that the lower the better, that there's no threshold in the association, and results have supported this finding. Further, time series studies have been used to assess the question of mortality displacement, because there was a large debate in the beginning that air pollution was affecting only frail subpopulation groups that would have died in the coming days anyways. If this was true, that we would expect a rise in mortality outcomes following a rise in exposure levels, that this will counteract and the mortality expected will follow in the coming days. In fact, what we have observed is that there is no mortality displacement effect, meaning that mortality raises after some days of exposure and remains higher than expected under a mortality displacement effect. This implies that not only frail people will die sooner, but also that people that are not frail to start with enter the pool of frail subpopulation groups, and the effects are more prolonged than initially thought. Apart from time series study to study short-term health effects, design has been the case crossover study, where in fact, if we have a case defined as a case of a health relevant outcome, we know the day the case has been observed, and we select comparable days in a bi-directional design that the event has not occurred. And according to this design, we also get an odds ratio or risk associated with the risk of observing the case on the specific day. There has been some projects that have used this approach. This can, under certain assumptions, be also considered to be equivalent with a time series approach as defined above. Here you see an example of an Italian study that selected, for example, 69 incident cases of cardiovascular hospitalizations. They had recorded the day of the hospitalization and selected days before and after the event to analyze the association between exposure to PM10 or PM2.5 with the risk of hospitalization, and have reached, of course, statistical significant associations. Panel studies have also been used. Panel studies follow for a period of time a small group of individuals, usually sensitive individuals, and they follow very closely with a lot of exposure and health outcome assessment, and this provides insight also in the mechanism of air pollution exposure health effects. But of course, because exposure measurements are needed and health outcome measurements are needed, this kind of studies are more expensive to follow through when studying short-term health effects. Here you see an example of a panel study that was conducted in Athens and Thessaloniki, the two biggest cities in Greece, where we recruited 100 children of about 10 to 11 years old from each city, and provided them with samplers, passive samplers, as Kees mentioned earlier, of ozone, and associated this with weekly measurements of their lung function or inflammatory markers. And we concluded that short-term exposure to ozone was associated both with decrease in lung function and also an increase in inflammatory markers and respiratory symptoms reported during follow-up. So although panel studies provide a wealth of individual data and have the power to detect associations with more specific health outcomes due exactly to the repeated measurements over time, and have also the validity of an individualized air pollution exposure, factors such as use of medication due to the health outcome that we are trying to detect may mask the associations, or the people that are willing to participate in the study may not be representative of the population we want to generalize to. So issues of bias may enter our discussion. Further, because exactly they measure outcomes that are not measured in a larger scale, health impact assessment is usually not based on panel studies results. How do we measure, or how do we investigate health effects of long-term exposure to air pollution? Starting from the lowest categorization of quality, may I say, of epidemiological studies, we may use a cross-sectional design where we select a sample of the population and we perform some kind of health outcome measurement and try to connect this to the exposure of the population, either at the residential address or to the nearest fixed monitoring site, for example. These kinds of studies are hired to include exactly selection bias, who is willing to participate in our study, and how the outcome and the exposure is assessed. That may also bias our results by introducing information bias. The temporality issue, what came first, the outcome or the exposure, may also be an issue. And you can see here a paper from the Netherlands that they measured vascular development in 5-year-old children that were selected in a certain area. And basically they concluded that exposure to nitrogen oxides and particles was associated with decreased vascular development in children. Another easy to conduct design to study long-term exposure health effects is to apply geographical ecological studies, meaning that we have a very wide spatial distribution, usually at country level wide, and we have a small area definition, maybe it's a municipality level or something according to that, and we have the assessment of some health outcome rate and the exposure outcome at municipality level, and we try to associate the outcome with the exposure. So these are easy again to perform exactly because the outcomes are usually come from routinely collected statistical data on mortality registries. You can see here an example where we applied this design to study air pollution and greenness effects using Kees estimates at a fine spatial grid over the whole of Greece, and then we assessed these exposures with a number of deaths that were observed in 2011, I think, over the municipality area. And of course, we concluded that PM2.5, black carbon, and NO2 were statistically associated with increased mortality data, while exposure to greenness was associated with less mortality outcomes. Excuse me. Another design to study the health effects of long-term exposures are case control studies. We recruit cases during a pre-specified time period and try to find comparable controls that have not presented the health outcome under study, and then assign them usually residential exposure estimates of exposure to see the association between the exposure and the health outcome. Now, when we study rare health outcomes, such as cancer outcomes, these studies have been particularly relevant because they have a low cost and can also address risk estimates pretty successfully. Nevertheless, still, the selection and information bias may enter part of the results of such designs. For example, here you can see a case control study that studied childhood cancers, and they selected incident childhood cancers from cancer registries in Denmark, and then found comparable, matched by age, sex, and calendar year children that had not developed childhood cancers, associated their outcome with a residential exposure, estimated, I believe, from dispersion modelings, and found that mostly, non-Hodgkin lymphomas were associated with increased risk following exposure to mainly PM2.5 and black carbon. The most important design to address the causality of the association between exposure, long-term exposure to air pollution and health effects is, of course, a cohort design. It's a longitudinal design that includes the individual data of the participants that they need to be followed for a large period of time, so we may observe the health outcome under investigation. Exactly because of the longitudinal design of this kind of studies, they are of high cost and they require large samples in order to be able to detect enough cases to have the sufficient statistical power to assess the small risk observed under air pollution studies. Of course, this may be easier if we use cohort data that maybe have been previously collected under another research protocol, a hypothesis, but now we have this cohort data availability, and if we go back and estimate residential exposure of the participants, it's easier to assess the associations without the need to start a new cohort and follow participants through time. As Kees previously presented, I show here an example of the results from the lab study that used Kees models, the harmonized modeling approach, to assess several pollutants over Europe. And these were used to assess the association of 7 European cohorts, mainly coming from Northwestern Europe, with the incidence of lung cancer. So the available cohort data were there, and we just pulled the 7 individual cohort data under a large new database and assess the association with the pollution estimates produced by the hybrid models. What we found was that PM2.5 was associated with increased lung cancer risk, even at very low levels, lower than the current air quality guidelines. Another way to address health effects of long-term exposure has arisen with the use of administrative cohort studies. Administrative cohort studies do not recruit people and follow them over a long period of time, as would be the case under a cohort study. But what they use is that they use already electronic health administrative database that they have the information. Each person usually is identified using a social security record, and through association of the longitudinal follow-up of the person through these administrative records, we associate the outcome under investigation with a residential exposure estimated by some of the methods presented earlier by Kees. The strength of administrative cohort studies is that they use available data, and usually they cover whole countries, so they have incredible statistical powers to assess even small risks. But of course, administrative data do not cover individual information, such as smoking habits or body mass index measurements that may be associated with a health outcome we tend to study. So methods have been proposed to compensate for lack of many individual confounders that may be of an issue in our estimation of the related risk effects. And part of this problem is solved by using area level covariates that are routinely also collected through censuses, such as unemployment rates in the area of the persons, or income, some estimate of the income in the neighborhood each one lives, or population density. This data that in fact would represent a socioeconomic status that may affect the association under investigation. Here you see an example of such an investigation using Rome administrative data to study air pollution, the occurrence of type 2 diabetes. They studied the association either using diabetes prevalent cases at the baseline when they started the follow-up through the administrative database, or with diabetes incidence during the follow-up of the period of the administrative cohort. And what the researchers found was that nitrogen oxides were associated with a statistical significant increase, both to diabetes incidence and diabetes prevalence. Now, cohort risk estimates are the ones that are most commonly used to inform health impact assessment exercises. And I'm not going to dwell on this because I know we have passed our times, and previous presenters have stressed the public importance of air pollution effects through several health impact assessments. And I also have here in this slide the global burden of disease project that assessed between 87 risk factors in 204 countries, ranging from 1990s to 2000 19 and identified air pollution exposure as a leading cause of death or a leading cause of disability-adjusted life years, both in males and females. In conclusion, the epidemiological design to apply depends on the hypothesis we intend to investigate, both in terms of exposure and outcomes. I would urge you, if you want to start such a research, that the easiest way to go through is to study short-term health effects by using a time series approach, while the most easier approach to study long-term exposure effects will be again by an ecological spatial design, or using available cohort data that have been collected possibly under other hypothesis, research hypotheses. Availability of administrative data are a very valuable source, but may be hard to get access to, and they need a very long period of bureaucratic processes. But this will be, I urge you also to go into this because they provide incredible power. As randomized clinical trials are not possible in air pollution epidemiology, statistical methods to address causality and the complex exposures have been developing constantly. And also correction to inherent biases, such as the measurement bias induced by the inappropriate exposure assessment methods, depending on the design. Finally, to conclude, risk analysis, and in order to have some introduction with the talks tomorrow, is largely based on long-term exposure health effects originating from cohort studies or meta-analysis of such studies, and usually address outcomes for which we have more consistent findings and hence a greater confidence on the association and certainty. Thank you for your attention.
Thank you, Efi, for this fantastic talk. And yeah, I apologize for everyone for going over time. We're running out of time slowly. So if you have any question, please write them into the chat box, and Kees and Epi will just answer them in the chat box. And with this, I thank everyone for listening, and I will hand over to Pallavi again.